Unfortunately, in India, we do not have any large-scale studies that would help us estimate the burden of childhood blindness. It is estimated from various small-scale studies that there are 3.2 lakh blind children in India. Cataract accounts for 12 to 14% of childhood blindness, which implies that there are 50,000 children with childhood cataract who would require treatment. The key to success in treating childhood cataracts is early diagnosis and treatment. Unfortunately, this does not happen many times. There could be many reasons. There are no routine screening programs in India. A child should ideally be seen by the pediatrician soon after he or she is born. Again, in the first year of life by a pediatric ophthalmologist. He or she should also be screened when the child reaches 3 years of age before he or she goes to school. Again, at 5 years of age. Unless this is done for all children, we will end up missing most of these childhood cataracts. There is also a need to sensitize pediatricians and other specialists towards early referral of these childhood cataracts. We should tell them that no child is too young to be treated. There is also a lack of awareness among parents. Some parents think that their child is too young to be treated. They feel that the child is very young, cannot be taken up for anesthesia, will not tolerate anesthesia and surgery, and they could wait until the child gets older. Unfortunately, by the time they come to us, it is too late. Some come from a very low socio-economic background. They are unable to afford the cost of treatment and travel. Some are not aware that treatment is available. Yet others are not aware that the child has a problem. This could happen if the child has cataract in only one eye. The child has good vision in the other eye, is able to manage well, and the parents often miss it out. Sometimes these children with cataract in one eye develop a squint. The parents think that it is only a squint, need not be treated early, can be taken to the doctor at a later stage, and often miss out the advantages of early treatment. If these children come to us late, we can never give them a very good visual outcome. The key to success lies in treating them as early as possible. If they come to us late, amblyopia has already set in and we have missed a chance for early treatment. Operating on a child with cataract is very different from operating an adult. Operating on a child requires special skill and special training and should be undertaken only by a person experienced in handling these kind of problems. The other problem that we face in treating these children is the associated comorbidity, meaning the other diseases that these children have. Many of these children are very young, so it is risky to give them anesthesia. Some of these children are so low birth weight and others have coexisting heart diseases. Managing all these children poses a significant problem for these anesthesiologists. Therefore, it can only be done in a center adequately equipped to deal with these kind of problems. Also, we need to educate that operating on a cataract is not the end, but the beginning of a very long journey. A very long journey meant to give them good vision. They need to understand that these children have to wear glasses after their surgery. In very young children, we sometimes do not put lenses. In these cases, these children have to wear thick glasses. The parents need to understand that only if they wear these glasses, only if they are compliant with the treatment prescribed, their child will get good vision. They can be made to understand that these glasses can be removed at a later date and be replaced with thin glasses once a lens is implanted at an older age. Also, in following up these children, we need to tackle the problems of amblyopia, we need to tackle the problems of glaucoma that can come over a long term. These children should be followed up at least every 6 months right into their adulthood. Only if this is done diligently and meticulously, we can achieve a good visual outcome. If the parents default on follow-up, if the parents default on their glasses, and if they refuse to take the treatment prescribed, the surgery will not be successful. We routinely implant intraocular lenses in children older than 2 years of age. For children younger than 2 years, the IOL implantation is decided on a case-by-case basis depending on the laterality, physical and mental status of the child. Technology has advanced by leaps and bounds, and we are able to take up these children for surgery as early as 4 to 6 weeks of age. For infants with bilateral cataracts, one eye can be done first and the other eye as early as a week later. For older children and in those in whom an IOL has been implanted, this gap could be increased a little more. It is important for doctors and patients to remember that no child is too young to be evaluated or treated.